Hello everyone, this is Elizabeth Santana presenting the mechanical ventilation case study number 4. The case study reads, a 63-year-old woman was intubated 4 days ago for respiratory failure secondary to sepsis from a presumed pneumonia. She is on appropriate antibiotics, is now off pressors, and her white blood cell count has climbed to the normal range. During your pre-rounding, you note that her FiO2 is down to 0.4, and she is on a PEEP of 5 centimeters of water. On these settings, the ABG shows a pH of 7.36, PCO2 of 46, PO2 of 75, and a bicarb of 26. She has a weak cough and continues with copious secretions requiring suctioning 30 to 60 minutes. The first question reads, at what point do you start considering whether your patient is ready to come off the ventilator? When considering removing a patient from the ventilator, you want to ensure that the underlying illness that caused them to go into respiratory failure has been resolved. Your patient should be hemodynamically stable, meaning off pressors, have a stable heart rate, not tachycardic or extremely bradycardic. The increased respiratory work while weaning and need for increased oxygen delivery can precipitate myocardial ischemia. The patient should be afebrile, since having a fever increases the body's oxygen demand. Consideration should be given into the patient's labs, since this will provide you a clinical picture on how the patient's overall function is, as well as clues to comorbidities. Questions such as, are they fluid overloaded? Is there renal insufficiency? Are there any electrolytes abnormalities? Would be answered. A low magnesium and phosphorus level can impair respiratory drive. A low hemoglobin can impair oxygen saturation. Potassium, a low potassium or high potassium can cause cardiac arrhythmias. A low calcium can cause muscle irritability, and low sodium can cause neurological deficits. The patient should have an adequate cough and gag reflex. The patient needs to have an adequate cough reflex to ensure that they are able to expel the secretions. Otherwise, your patient can potentially aspirate. Arterial blood gas and ventilator settings should be taken into consideration. The patient's PaO2 should be greater than or equal to 60 on an FiO2 of less than or equal to 0.40 and a PEEP of 5. A pH greater than or equal to 7.25 is a standard criteria, and this is according to the evidence-based weaning guidelines task force that was created by the American College of Chest Physicians, American Association for Respiratory Care, and Society of Critical Care Medicine. While the patient is intubated and sedated, studies have shown that daily sedation vacation not only allows you to evaluate your patient's neurological status, but also decreases the time on the ventilator and in the ICU. The mental status is important. You want to make sure that your patient is awake enough to follow instructions for the weaning process. You also want to take into consideration how long ago their sedation was turned off. They should really be free of sedative agents that may potentially inhibit their respiratory drive. So coming back to the case study, we're noting that the first criteria for weaning is going to be underlying illness. It mentions that the patient is on appropriate antibiotics, she's off pressors, has a normal white blood cell count. This is all indicative that the original underlying illness of sepsis from presumed pneumonia, which caused the respiratory failure, has been corrected or is being corrected. The next criteria speaks of ABG parameters, a PaO2 greater than 60 which the patient's PaO2 is 75, and a pH greater than 7.25, and the patient is 7.36. Hemodynamically stable. Again, the patient in the case study reports that she is now off pressors, does not give information on their heart rate or blood pressure, but based on that sentence, we're going to assume that the patient is hemodynamically stable. An adequate cough. The patient is reported to have a weak cough with copious secretions that require suctioning every 30 to 60 minutes. We will go further into this later on in the PowerPoint. Ventilatory settings, an FiO2 of 0.40 and a PEEP of 5 is what the patient's currently on, and that does meet the criteria. How do you determine if the patient is capable of being separated from the ventilator? That is the second question in the case study. The decision to extubate a patient is multifactorial. The following are key components in ensuring a successful extubation: respiratory drive, diaphragm muscle strength, gag, cough reflex, laryngeal function, level of consciousness. Respiratory rate is a simple way of noting respiratory drive, noting how many breaths the patient takes over the ventilator. During spontaneous breathing trials, it provides the clinical information on how well the patient is tolerating the trial. A maximal inspiratory pressure, also known as MIP, provides information on the strength of the diaphragm. Less than -20 to less than 30 centimeters of water are acceptable ranges for extubation. Vital capacity is the amount a patient is able to exhale after being asked to take a very deep breath. An acceptable value is greater than 15 milliliters per kilogram of the ideal body weight. A respiratory frequency to tidal volume, also known as rapid shallow breathing, is measured while the patient is off the ventilator for 1 minute while spontaneously breathing. If the calculated amount is greater than 100 breaths per minute per liter, weaning failure is very likely. CROP, which stands for compliance, respiratory rate, oxygenation, and inspiratory pressure, is used to assess respiratory muscle fatigue. A value greater than 13 is indicated as a successful extubation parameter. A study conducted by Duan, Zhou, Zai, Liu, and Yang in 2015 noted that a cough peak flow is a good indication to establish how the patient is able to cough and see if they're able to clear their secretions. The downfall to the study is that you would require the patient's cooperation in order to successfully be able to gather the measurements needed for the study. An easier way to establish whether your patient has a cough or a gag, and that's while they're intubated, is to inline suction them. That usually provokes a coughing and gag reflex. Laryngeal function is important since a complication of long-term intubation can be laryngeal edema. This can cause stridor once the patient is extubated and cause for much more difficult intubation afterwards. So in a patient that you may suspect that may have laryngeal edema, you want to perform a cuff leak test. Mental status is important overall because you want the patient to be able to follow instructions and communicate with you as best as possible while intubated and while going through these trials. The patient, of course, should be awake and free of sedative agents. A spontaneous breathing trial is a reliable way of ensuring your patient will be successful during extubation. The patient is taken off the ventilator, usually with pressure support to ease the discomfort of the breathing through the ET tube. The initial trial can be only a couple of minutes to see how the patient will do. If the patient exhibits being able to continue with the trial, this can last 30 to 120 minutes. Close monitoring is required during the spontaneous breathing trials, assessing for adequate gas exchange. This can be done with arterial blood gases as well as evaluating the patient's breathing patterns. Monitoring the patient's heart rate, blood pressure, and EKG rhythm to avoid complications is very important. According to our mechanical ventilation textbook written by Cairo, quote from page 398 states, studies have demonstrated that 77 to 85% of patients who pass a spontaneous breathing trial can be successfully weaned and extubated. Prolonging a spontaneous breathing trial while the patient is failing can cause considerable damage. It can cause muscle fatigue, hemodynamic instability, as well as worsening of gas exchange. During the trial, it's imperative that you pay very close observation to the patient and note the characteristic signs that the patient is failing, such as an increased respiratory rate greater than 35, or 10 breaths above or 8 breaths below the baseline, an oxygen saturation that is declining, a heart rate greater than 140, or 20% increase from the baseline. You will note decreased tidal volumes, your significant change in systolic blood pressure, greater than 180 systolic or less than 90 systolic. The patient will appear diaphoretic and extremely anxious. These are all indications that the patient is not tolerating the trial and should be back on mechanical ventilation and sedation if needed. However, studies have shown that a patient that passes the spontaneous breathing trial can be extubated with very low occurrence of reintubation. The third and final question of the case study reads, suppose your patient demonstrates that she can't be separated from the ventilator. Should she be extubated? Although this patient fits the criteria and is demonstrating that she can be separated from the ventilator, the answer that I provided for this question was no. I do not think this patient should be extubated. The rationale for saying no for this patient being extubated really focused in on the amount of secretions this patient had, how often she needed to be suctioned, as well as her having a weak cough. During this project, I conducted and read several literatures on several studies with regards to extubating a patient, failing parameters, weaning parameters, as well as what is needed for successful intubation and extubation. One of the things I kept coming across was a patient that has copious amounts of secretions has a high rate of failure. The first study on the left-hand side states, a patient that's reintubated has a higher intensity of care unit mortality rate, showing a statistic of 26 to 50%. The second study showed moderate to copious tracheal secretions and a PaCO2 more than 44 during spontaneous breathing trials can independently predict extubation failure. Note that the patient's PaCO2 level to begin, this is even prior to the spontaneous breathing trial, was 46, which is on the high normal or just above the normal. In the same study, patients with moderate to abundant secretions were 3 to 8 times more likely to fail extubation. Based on all that information, I felt comfortable saying no to extubating this patient and monitoring her for another day if not getting more data to see what we could do to help with the amount of secretions that she's experiencing. Thank you all.